Welcome, everybody. You are in the Silver Hill Hospital Grand Rounds program. Thank you for joining us, and we will get started in just a moment as people settle in. All right, I will go ahead and get started. Thank you, everybody, for being here today. Hello and welcome. I'm Dr. Jeff Katzman. I'm the director of our um, of education at Silver Hill Hospital and of our SHARE program. That's the Silver Hill Academy for Research and Education. And we are absolutely delighted to have you join us today and really very privileged to welcome Dr. Benjamin Israel, who is on the board of directors and the International Society for the Study of Trauma and Dissociation. And I will read to you and talk to you more about him in just a moment. Also joining us today is Dr. Emily Haas. Thank you, Emily, for being here with us. Dr. Haas is the director of the Triumph program, Silver Hill Hospital's trauma program, and a longtime colleague of Dr. Israel's. And Dr. Haas will join me in moderating the Q&A portion of our presentation today. Some housekeeping to start. This will be our final grand rounds for 2025. Please watch your inboxes for 2026 grand rounds invitations. We have a year of really fantastic programs lined up, and I'm excited to share that with you. For a list of all the upcoming Silver Hill and SHARE events, please visit us at silverhillhospital.org/calendar. As always, your questions are a really important part of our Grand Rounds program. And as I said, Dr. Haas and I will moderate a Q&A discussion with Dr. Israel at the end of his lecture. And it's really a great opportunity for you to put forward questions and comments. And you can submit those anytime during the lecture by using the Q&A link. That's much better than the raise the hand function, so don't do that. Use the Q&A link. Also, if you would like CME or CEU credits today, please complete the evaluation survey that will pop up in your browser at the end of the webinar. A link to the survey will also be emailed to everyone tomorrow. This email from SHH Events will also contain a link to the recording and slide presentation. The survey will remain open until the end of day on Friday, and certificates will be emailed within a week. Please note that while doctors may receive partial credits based on the length of their participation, all other attendees must participate for the full 90 minutes in order to receive credits or certificates. Any questions, just contact us at shhevents@silverhillhospital.org. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest, and Dr. Israel will show a slide with his disclosures. So with that, it is now my great pleasure and honor to introduce our guest speaker today. Thank you, Dr. Benjamin Israel, for agreeing to be with us today and saying yes to our invitation. Dr. Israel is a psychiatrist and psychotherapist and researcher, specializing in the treatment of PTSD and dissociative disorders. He previously served as service chief of the Trauma Disorders Program at Sheppard Pratt Hospital, a national referral center for complex trauma and dissociation. At the University of Maryland School of Medicine, he worked in consultation liaison and emergency psychiatry, launched trauma-informed services in the Division of Addiction Research and Treatment, and served as co-investigator for grant-funded research in trauma-informed health systems. Dr. Israel is associate editor of the Journal of Trauma and Dissociation and serves on the board of directors of the International Society for the Study of Trauma and Dissociation. His peer-reviewed publications include comprehensive reviews and analyses of trauma-informed healthcare practices in addictions medicine. He also provides clinical supervision and consultation to clinicians at all levels of training. In 2023, Dr. Israel founded Featherglass Health, a trauma-informed digital platform transforming care quality and stakeholder experience in healthcare. And he currently serves as the CEO of that organization. And I have known Dr. Israel for some years now and have had um, really great opportunities to talk about psychiatry and psychotherapy and patients. And it's been an honor to be your friend and colleague, Dr. Israel. And thank you again for saying yes to our invitation today. And Dr. Haas and I will blink out here, turn off our videos, but we'll be back for our fireside Q&A after about hour and 10 minutes of your presentation.
Thanks for that kind introduction, and it's great to be reunited a little bit more with you, Dr. Katzman and Dr. Haas, and all. Thank you so much for being here, and thank you, Silver Hill, for hosting me. I'm going to get my slides shared here. Okay. So this talk is called Trauma-Informed Mental Health Care in the Age of AI. And I chose this slide of two people holding hands because I can't speak for everyone, but I think I've noticed increased angst, concern, sometimes excitement, but concern about what does artificial intelligence mean for the practice of behavioral health care, psychotherapy, healthcare in general. What's happened to the human touch? And in our work at University of Maryland, prior to my current role and other places, one of the most common concerns has been it's hard to accomplish that human touch, even in the status quo, especially in large health systems as well, where patients, particularly patients that we treat in psychiatry and behavioral health, they frequently feel lost in the system. And human beings, even in the era of uh, legacy electronic record systems, human beings feel lost in the system. And they get asked the same set of questions everywhere they go by people who are trained healing professionals, caring professionals. And the system has a way of being dehumanizing. There's a lot written about this, about institutional forms of dehumanization and even betrayal in healthcare. And I want to propose that we have problems, opportunities, but also challenges to address here. And staying centered on human connection is my natural center, and it's where I'll attempt to keep our center in this talk. As Dr. Katzen mentioned, a couple of years ago, I started a company called Featherglass, which specializes in trauma-informed AI-powered services for health systems. I don't have any other conflicts to disclose. I won't be talking about our work or our aims or any projects or features we're developing as part of that endeavor. This is uh, uh, going to be focused on the topic that I mentioned. We have three objectives. One is identify three core principles of trauma-informed practice, describe two conventional interventions, so pre-age of AI interventions that can empower both patients and service providers in trauma-informed behavioral health treatment. And finally, describe one risk and one opportunity that artificial intelligence-based tech might present for care from a trauma-informed lens. So to do this, we're going to have to define a few things. And I tend to be a little bit more definitional in my base approach, I think, compared to most folks. So if that is helpful, terrific. Just to get to these questions, we need to define what is trauma, what is treatment for trauma, what's trauma-informed practice, and by the way, what is AI? What does that really mean? This is kind of like the answer sheet. So if you we're going to get to the question of defining these, right? Of what's trauma-informed practice, what is AI? But this is one way to represent graphically um, my aim in this talk, which is, well, if we can define trauma-informed practice functionally as 5 tasks for a service, a hospital system, a healthcare system to understand trauma or realize trauma, to be able to recognize signs and symptoms of trauma in various ways, to respond effectively when signs and symptoms of trauma become activated, to have systematic policies, procedures, and practices that resist re-traumatization, that attempt to be like guardrails, preventing trauma or re-traumatization from happening. These are all part of a well-accepted framework, first published by the U.S. Department of Health and Human Services about 11 years ago. And there's a fifth piece that I'll propose is equally important, repair, because ultimately, no matter how hard we try, not dissimilar from psychotherapy, where impasses happen, even not as a defect, but as a feature often of long-term therapy. Harm happens in systems, no matter how hard and conscientious, no matter how hard we try, no how conscientious we are. It's often difficult to talk about that in health systems, depending on the culture of the system and who's there and other factors. But if this is a functional definition of of the tasks that need to happen for trauma-informed care to presumably occur, where does AI link with that? I'll tell you one thing I'm looking not to discuss today. Um, we're not going to talk about psychotherapy chatbots, in part because this is what's taking up most of the oxygen in the media, I think in the popular imagination, in the professional imagination, as I'll show later. The first randomized control study um, was published less than a year ago, earlier this year, showing that a psychotherapy chatbot seems to be safe and effective within the criteria, the parameters of the study. This is the title image from an article that came out about 2 weeks ago from Wired magazine, um, late October. It's the best one I've read if you're looking to read about this. Really an impressive journalistic achievement, showing how two patients with one of them had significant trauma, complex trauma, and dissociative symptoms, used AI for better or for worse for a prolonged period, and really brings to life the experience of working with a chatbot for an extended period of time that I don't think is captured many other places. We're seeing a lot about the risks, of risk of harm, about some absolutely nightmare cases. But I want to propose that we can take a step back from this and think more broadly than chatbots, because there is so much more to this conversation, both in terms of opportunities and potentially in terms of risk. Whenever I talk about trauma and trauma-informed practice, particular, and also for this conversation about AI, I just want to acknowledge that any conversation about trauma is going to be different for different people listening. I have my own blind spots and learning points that I may or may not be fully aware of, and my background and my advantages and blind spots come to every conversation. I also want to point out that I come to this talk not as a technical expert. So I am not a technical expert in artificial intelligence. It is something I have had to learn as we synthesize and meld our fields, which is happening whether we like it or not. And if any questions come up that I'm not able to answer about AI at the end, I will be as transparent as I can about where my knowledge personally ends. I'd like to start with a case. So Donna F. is a fairly typical patient that I saw while working in psychiatric emergency services in inner city Baltimore a number of years back. She's a 46-year-old African-American female. Um, Oops, Zoom is blocking my view. Depressed, with vague suicidal thoughts. She described having an abusive romantic partner. She had multiple psychiatric diagnoses in a history, schizoaffective disorder, bipolar disorder, several substance use disorder histories. She had had many hospitalizations and psychotropic trials. Her first hospitalization and psychotropic trial was when she was 11. She had a history of skin infections, largely secondary to her substance use, asthma, hypothyroidism, so some autoimmune issues. She had a history of cutting, both superficial and deeper cutting, and multiple overdoses on sedating medications and substances. She had completed her GED. She was unemployed and had very insecure housing, sometimes staying on the streets, sometimes staying with people she knew. When the resident I saw her in the psychiatric ER, she was depressed and actually described hearing voices since middle school. So since before she became a teenager. She described manic episodes, which had come up in earlier evaluations in the same ER. But when we really pressed for details, she said, "Oh yeah, I don't. It's usually a few hours. It might go up to a day or two, which of course is much less than the DSM criteria states that a manic episode really needs to be a week or longer. But while sober, these symptoms never lasted more than a day or two. She described re-experiencing past symptoms of trauma and adverse events. And it wasn't just visual flashbacks or hearing sounds from these events. She felt them in her body, and she often even smelled what was happening, even though there was no way those scents were in the room. On mental status exam, her affect was constricted. She was goal-directed, seemed very organized, even with perhaps obsessionally organized and very detail-oriented. She described experiencing auditory hallucinations and some of those post-traumatic intrusions at times in the interview, but she wasn't outwardly reacting and she remained very organized. So this is the kind of patient who often comes to the ER many times, right? Whether, especially in this particular site, which was in inner city Baltimore, and gets lost in the system and might, depending on who she's meeting and what kind of day it is, and if she's had recent exposure to substances, may describe her story in different ways at different times. And different clinicians may ask about her story in different ways at different times, right? So if we just put, how do we treat her, this patient, in a way that's trauma informed? What does it mean to be trauma informed? Well, obviously, trauma is related to this. There are thousands, if not millions, of people in the US who interact with our system who are at risk of getting lost, who may have trauma, who have the system has a hard time really seeing people and hearing them and listening to them. So there's clearly also a public health piece, right? And those of us who went to medical school didn't learn very much about public health in medical school, right? What else is connected to trauma-informed care? Well, obviously, medicine, migration histories, your education, social determinants of health issues, issues of health equity and access, language barriers, how the organization works, how the organization approaches quality improvement and communicates internally about that. Often there's intersection with the justice system, obviously research. And then, oh, by the way, there's specialized treatment for trauma, whether it's psychodynamic psychotherapy, EMDR, cognitive processing therapy, exposure therapies of other kind. These all intersect. So trauma-informed care, as I was discovering in my earliest days, getting into research, is a vaster topic than where I started out, which is becoming a specialist for helping patients stabilize treatment for trauma. This is really vast, and it is, and then the further you look, the more processes and institutions intersect here. Trauma, we can we can simplify that graph a little bit and focus our attention here. What's the difference between specialized treatment, like prolonged exposure and the other modalities I mentioned for psychotherapy, maybe some psychopharmacology, and trauma-informed care? And how do they relate to what trauma is? So that's where we're going to go. We need to take a brief detour, though, because we're also talking about AI today. So what does artificial intelligence or AI mean? So we'll start here and then we'll loop back and then we'll weave these themes together the best that we can. AI, like most terms that we talk about and read about in the news every day, really has multiple meanings. So the everyday meaning is anything a computer does that seems smart. So we've been talking about AI and seeing films about AI for a long time. And I think this is a valid everyday meaning. There is no single agreed upon meaning in everyday discourse about what AI really means. So it can help to clarify. On the technical side, AI does not just mean ChatGPT and large language models, LLMs. It's a larger set of many different approaches. So LLMs, which is the architecture powering ChatGPT and Google's Gemini and Claude and Meta has a system and others, is just one branch. It's the most prominent branch, the one most people have heard of these days. It's also a more recent branch. So there are other fields of AI considered equally important to this discussion. There are classical symbolic kinds of machine learning. There are programs that can solve and prove mathematical proofs at a deep level that cannot rely on LLMs. They have other architectures. There are different architectures for machine learning. You might remember more than 10 years ago, certain apps on our phone were able to recognize pictures of our friends and family. That wasn't using an LLM, that was using other forms of deep learning, using deep neural nets. And there are even different architectures to deep neural nets, like recurrent neural networks and convolutional neural networks, which are particularly useful for image recognition. There are other statistical models that are more probabilistic. There are other models focused on robotics and perception. And then there are hybrid systems, which is what we're starting to see more and more, especially this year, trying to combine the strengths of different fields. So the title was sort of a little bit tongue-in-cheek, calling this the age of AI. AI has been a substantive conversation in the technical literature for nearly 80 years, at least since the late 1940s and early 1950s, when Alan Turing coined the famous Turing test, which is essentially a test where if you're talking to a machine and you can't tell if the output is from a human or a machine, it counts as an intelligent system. A few years later, there was a conference, a funded conference, at the top story of the math department for about 10 weeks at Dartmouth College, where a group of eminent researchers essentially brainstormed what intelligent machines, thinking machines, could mean for the field and for the world. And the term AI was coined then in 1956. Then we enter a time that was both exciting and also quite slow in hindsight. In 1980, the first neural networks were theorized and built. By the mid-1980s, the second generation of neural networks were being built. So really, there was a lot happening, but there wasn't that much we could show for it. And this time between 1980 and about the time in 2012, some people call the AI winter. But people were working, researchers, technologists were working on this despite not being able to show a commercializable product for a very long time. I remember very clearly when a system called Deep Blue defeated Garry Kasparov in a series of chess matches in 1997. We saw more progress after that, and of course, we all remember the ChatGPT moment 3 years ago, almost feels like longer to me, when suddenly these large language models, a new architecture for learning and responsiveness with thinking machines, broke onto the scenes, and now we're seeing multimodal and agentic level AI. You can see on this graph, and this is a logarithmic graph, so every increase, a straight line going up here actually is supposed to represent an exponential rise in computing power that we are able to leverage to support AI systems. And you can see around in the early 2010s, that curve just increased even faster than we saw before. So the training computation was doubling every half year or so, including up to today's models. This paper has been cited more than 200,000 times for the researchers in the group. This always is humbling. This was published less than 10 years ago. This is the paper that launched 1,000 startups, including my own. It's called "Attention is All You Need." This is the paper that came out of a research team at Google that discovered or innovated and described the discovery of a new architecture, a new way of analyzing language, originally for the purpose of translating text from one language to another. And the paper is only 6 or 7 pages. About half of it is you really need to have a technical background to delve into. But the other half isn't that hard to read. And you can, if you squint a little, see a little bit of the history of this field unfolding through reading this paper, right? Um, I just highlighted the word parallelizable here. Simple neural network architecture, the transformer, was more parallelizable significantly than other architectures, right? And what that means is modern AI systems are able to use parallel calculations at scale, right? And so this is why NVIDIA is now considered the most valuable company, because they create chips that do computations in parallel, as opposed to the chip that's running my computer now, which is called a CPU. These GPUs, or graphics processing units, are really one of the key breakthroughs that allow this technology to scale. And you can see in this paper what was really amazing is this team just bought a few NVIDIA chips off the shelf, stuck them in a computer, and outperformed using this new architecture for computing, outperformed supercomputers trying to do the same thing using the previous generation of machine learning. So this is really the moment in 2017 that launched the age that we're in. The purpose of a transformer is to analyze a group of text, not sequentially, but all at once, as an input, and generate an output that makes sense to the human reader. This was originally done in translation. So you can see the previous models relied on an architecture called LSTM, long and short-term memory processing, a form of a recurrent neural network. And the time it takes to process this short sentence, "You are welcome," increases with every word. Whereas with a transformer, which powers ChatGPT and similar um, LLM models, in the same time, you can process the whole sentence, whether it's 3 words or a longer sentence. It's helpful to know that these models have many layers of functioning. So this is just an example of 2 sentences. The cat drank milk because it was hungry or because it was sweet, right? So the LLM needs to be able to understand what the word "it" means. And in the first sentence, by digesting all words at once, the LLM needs to be able to understand that "it" correlates to cat, whereas in the second sentence, "it" correlates to milk, right? So they have a numerical technique called embeddings that allow these relationships to be recognized extremely fast by these parallelizable systems. Another interesting feature for those interested in layers of meaning, if you work in, for example, relationally focused psychotherapy, is that LLMs, uh, in a way, work with layers of meaning as well. So the transformer block, as it's trained, im- develops layers that can analyze a sentence at the same time at different so-called layers of meaning, starting with the concrete and syntactical, moving all the way up to high levels of concept and abstraction. These models don't have a model of mind, as I'll mention in a moment. They don't have an internal working model like we talk about in object relations or attachment theory and others. But they do process immense amount of information simultaneously in layers. All the LLMs are essentially baked in a similar way. There are a few key ingredients to the transformer and embedding layers and the inputs. And there are a few key ingredients to creating an LLM from nothing. You need an immense amount of training data. The LLM essentially does pre-training and teaches itself. And then we have two steps that are designed to help refine the output from the LLM. So this is called the fine-tuning step, and this is human reinforcement learning, RLHF, reinforcement learning with human feedback. So when you hear about so-called safety features that an LLM is supposed to have to guide its output and make sure it's safe or appropriate or not saying something completely biased and potentially harmful. This is the step of essentially baking the cake that is supposed to help with that. We have not mastered this. There are ways that you can defeat LLM's safety features essentially by wearing them out that we won't get into here. But when we talk about AI, it means a lot of different things, not just LLMs. And LLMs are notoriously bad at doing certain things. So what kind of reasoning can LLMs do? Can they reason at all? So this is really a critically important point about the state of the art. So there are two main kinds of reasoning that we think about with computer models these days. They can write paragraphs, they can write papers that look well reasoned, but the only kind of reasoning that this correlative statistical method at its core is capable of doing is inductive reasoning. So inductive reasoning is where you take a couple of specific observations or more and translate those into a general statement. So my dog is friendly. I observe my neighbor dog is friendly. Thus, all dogs must be friendly. That is inductive reasoning. That's different from deductive reasoning, in which a conclusion is deduced from an observation and an axiom. So all people are mortal. That's an axiom. Socrates is a man, therefore Socrates is mortal. So LLMs cannot do this. They also they can mimic it, but if you ask an LLM to do deductive reasoning or other types of strategic planning for more than a few steps at a time, even the most current models are not able to do it, right? So when you hear about a machine learning system defeating the world champion at Go, which happened a few years ago, that wasn't an LLM. That was a completely different architecture used in AI. And so we have folks, this is one of the most famous AI researchers named Yann LeCun, stating last year, if you're a student interested in building human level AI, just don't work on LLMs. They have these barriers built into that way that they process data, and there is no cure for them. It is not a defect. This is a feature of the current state of the art. Interestingly, inductive reasoning is how we're trained to think in medicine often, right? We have a number of studies. And my first study says that Prozac helps with treatments of depression. And my second study says that Prozac or fluoxetine helps with symptoms of anxiety. And we have a number of studies that say similar things. And we say, well, therefore, Prozac must help a lot of people with depression and anxiety. So and we can get far in some cases with this. And we're trained in medical school, in medical training, to also see that this kind of reasoning has gaps and blind spots, and the idealized conditions of a clinical trial may not help us fully in the real world, like with the case of Donna that I mentioned. She would not qualify for any large scale clinical trial. She would be excluded on so many factors, whether it's the housing insecurity, the multi-comorbidities, the substance use, and atypical symptoms, and so on. But we use inductive reasoning in journal clubs and medical training all the time. We also use a lot of these safety mechanisms in training to challenge our inductive reasoning and try to stay grounded. But LLMs really need to be taught to do this, and sometimes they're more successful than others. So that's what you get with an LLM. Finally, before we shift back to the trauma-informed service, what is AI? What is it really capable of doing, right? So now we have a sense of what AI is, what it's not, what it can and can't do, especially in the world of large language models. What can they do, right? So they can advise us, they can summarize text, hopefully without making too many errors. Um, they can potentially assist us where agents and humans start to work together. They can maybe start to execute tasks, like we think of a medical trainee executing tasks under the close and diligent supervision of the human. We see this happening, these assistive and assumptive steps happening in coding these days, where AI agents are being treated almost as junior coders. And sometimes it can work out well, and sometimes it can be a little bit disastrous. And then full autonomy. So we're nowhere near here. And in medicine, really, we're looking at using AI to summarize in responsible, safe ways. We're not asking AI to make diagnoses and certainly in behavioral health. And this is where you start to need uh, extra um, uh, extra regulatory standards like FDA approval, different levels of approval to use really any digital system, and I would think particularly AI in a safe and responsible way. But we don't really know the best way to regulate this yet. We're at the frontier and still figuring this out. So AI is coming into our health systems, and trauma-informed care is a health system-wide issue, whether you just work in behavioral health or if you have a multi-specialization system, like where I used to work at the University of Maryland or Johns Hopkins or at um, most freestanding hospitals. So what is trauma-informed care, and how does that relate to specialized treatment for trauma? So we'll propose that trauma has three main components to really clarifying what trauma is, and trauma-informed healthcare has the five that I mentioned. And we'll think about what's the role of AI here. So we'll put up some let's see here. We're building some tents. We'll put up some tent poles. We have one tent pole for defining AI. We've started to define trauma-informed practice, and we'll see how far we can go to get the big top tent up here. This is a study by Rebecca Cole, who's runs a nursing team or ran a nursing team in one of the largest hospital systems and ER systems in Hawaii, showing that implementing trauma-informed principles in a very creative and thoughtful way, over 2 years, her system was able to reduce the use of restraints in the emergency department from nearly every day to 0 times a day at the end of the study. This is not a study I learned about, is I was learning how to do specialized trauma treatment. This was in a general emergency room, not a mental health or behavioral health specialty emergency room. And sadly, there are very few studies like this. This is still an emerging field, even though this was published more than 10 years ago. Now, if you're looking for a Journal Club article, it happens to be a very well written article, and I think a compelling one to demonstrate how in research we can move from these randomized clinical trials, high level traditional designed for clinical trials, to these implementation science model that we need to really study health systems and how we implement trauma-informed practices here. In trauma-informed practice, we're not talking about reducing people's PTSD symptoms overtly, like nightmares and flashbacks. We're thinking about outcomes like this, and how do we work as a team to collaborate with each other and with patients to make treatment work better. So that's just a concrete example of where we can go. And there are precious few articles still to this day in this direction. What is trauma? It tends to mean different things to different people, similar to AI. There are more types of trauma than I know how to specialize in. We talk about war trauma, which is not my specialization. That's largely um, uh, uh, considered in the VA system, of course, in this country. There is human-made disasters, there's natural disasters, there's other trauma related to exposure to war. There is child sexual abuse, sexual harassment. This is a mural from India. There are cases of neglect, severe neglect. There's trauma from extreme challenges and social determinants of health. This is an image from Baltimore City, where I live. There's trauma related to family dynamics and other kinds. These are pictures from the late 1960s from the Vietnam War. And as much as in my field we think about trauma and PTSD, it's helpful to point out that there was no such thing in our lexicon as PTSD at the time these pictures were taken. So PTSD wasn't codified and recognized as a diagnosis. Trauma wasn't recognized as a legitimate cause of difficulties in mental health until 1980, when the DSM-3 was published. And this had largely to do with the Vietnam War, in part because so many people came home from the war with symptoms of trauma that people started to recognize it even more than they did in past wars. Probably more important is that this was the first major war where journalists were allowed to be there and able to document what was happening. We had about a quarter to a third of the casualties in World War I and World War II, which of course were much larger in scope than Vietnam. About a quarter to a third of those casualties were directly related to trauma. We called it shell shock in World War I and combat fatigue in World War II. And we were treating people with effectively memory processing techniques and sending them back to the battlefield in those times. But still, there was no PTSD. There was tremendous political inertia working against the recognition of trauma until reporters went into Vietnam. So PTSD had a bit of a slow start in our own field, which is part of a much longer story. But now we recognize it, and we recognize that there's not just one kind of PTSD, there may be multiple kinds, like complex PTSD. SAMHSA has defined trauma differently from the DSM. For public health purposes, this is a much more useful and actionable definition from what I learned in psychiatric training. The three parts of trauma in the D, and according to SAMHSA, this is from 2014 report, include trauma has to result from an event or multiple events. Those events have to be experienced by the person as physically or emotionally harmful or life-threatening. And that event has to have lasting adverse effects on that person's functioning and mental, physical, social, emotional, or spiritual well-being. This is really vastly different from how trauma is defined in the DSM, is essentially a life-threatening or nearly life-threatening exposure or secondary exposure, like reviewing evidence from a crime scene that causes PTSD symptoms. In this definition, it has to cause lasting adverse effects, but they don't have to be, they could be depression. They could be problems with functioning. They could be more in anxiety spectrum. They could have to do more with social functioning or even spiritual functioning, which is much more realistic on the ground level. Trauma is difficult to study because it's hard to measure the many array the array of all the effects that these adverse experiences can cause. If you do an image search for adversity, you tend to find lots of pictures of plants growing from cracks in the concrete, or of white men pushing boulders uphill. There are these this person is in the shadows, but if you do a Google search, you'll see lots of images like this. Um, Adversity has a more a very different set of connotations to many people than trauma does. But our studies of trauma prevalence tend to focus on adversity, right? Have you been exposed to an adverse event? That is a much simpler research question to ask than have you been exposed to it? Did you experience it? How did you experience it? Has it led to long-lasting effects? There's so much more subjectivity baked into that question. So all of our studies on population health that have to do with trauma generally look at adverse childhood experiences. And that's the landmark study and series of studies starting in the 1990s that are continuing to this day. Um, Looking at trauma. We really have to study adversity, and we can't look at the full complexity of trauma and all the various effects it can cause. We know also there's a growing evidence base that the DSM definition of trauma is really very inadequate. So they're so-called little t traumas, these tiny, this is the pincushion representing smaller but perhaps more numerous events that can really hurt someone and cause lasting negative effects, just like in the SAMHSA definition. We've talked a lot in recent years about microaggressions, people being gaslit. Really, this is a form of bullying. There's a literature on a really coercive, controlling kind of bullying called DARVO, deny, attack, and reverse victim and offender roles, which we see in abusive relationships all the time. Identity theft, other kinds of relational betrayals, discrimination and stigma when it becomes systematized. Traumatic invalidations has a literature in the psychotherapy, is part of the psychotherapy literature. Some forms of neglect. None of these are really captured in the DSM-5 definition of trauma in criterion A of PTSD. But we really have finally in the last less than 10 years a growing evidence base showing that these exposures predictably cause lasting and substantial impacts on someone's emotional state, their symptoms, and their functioning. So there is more to the story yet to be told, but it's finally showing up in the evidence base. Double binds are one of these examples that often show up in complex trauma therapy. We have a couple slides showing what they are. It's like the ultimate little t trauma, where a person's stuck in a situation where they're damned if they do, damned if they don't, and there's no way out. Every option leads to some kind of punishment, even if it is a seemingly mildly punishment. And so here's a cartoon about double binds where the smiling boss says to the young employee, you can make your own decisions, but I'll make sure that I check everything first, right? And even a small, seemingly small interaction like this in the workplace, in this power dynamic, drives us into confusion and paralysis and agitation. And this is what children who grow up in abusive households live with, but at a much more severe and damaging level. And these are the dynamics where you're damned if you do, damned if you don't, that often show up in the transference relationships in psychotherapy, where the therapist may feel like they're in a bind, where no matter what they say, it's not going to be good enough, it's not going to be right, something's going to be sabotaged. And so we work through this in therapy. But there's actually a larger literature about double binds involving way more than broader fields in the psychotherapy field that we could talk more about. In complex trauma, we also have a great deal of focus on the nature of shame in trauma, in PTSD, in complex trauma-related disorders, and how people act out their shame, right? So people with severe shame uh, have four typical ways of acting out, and this is based on. Well, I'll bring up the references here. You can actually study this and show that folks with trauma exposure are more likely to act out in fairly predictable ways. So the so-called compass of shame responses, where I avoid how I feel through sex, drugs, or rock and roll. So I have a difficult day at work and I go on a weekend bender. That's the classic avoid response to shame. I withdraw, so something difficult happens, and I lick my wounds in private and and lock the door so no one can see how bad I feel. I attack myself physically or through negative self-talk. I'm stupid, I'm bad, I'd be better off dead, so on and so forth. and attacking others, right? And most people that I've met, clinically and otherwise, seem to have a constellation of all of these, right? And probably one of the most common form of attack others is gossip, right? Where for a moment I might put someone down to lift myself up a little bit and not think about how I really feel deep down. Um, so what's interesting is that this is actually has an evidence base, including a compass of shame scale. There's an evidence-based scale that Contractor and colleagues published several years ago showing that if you follow these behaviors and don't worry about asking patients about symptoms, you can actually predict the likelihood that they have PTSD. So there's an emerging story in the clinical evidence supporting this narrative that came from the psychotherapy literature. Judith Herman wrote a wonderful book chapter called PTSD is a Shame Disorder that I used to have residents look at. You just can't overstate the instance here, the importance of this issue. And why I should use this slide here instead of in a psychotherapy talk is look, think about Donna's case, right? What's happened with her? She's had attack self. She's had avoid responses. She withdraws at times, right? She's been a victim of exposure to aggression, and she may have acted out aggressive impulses in the past as well. So this is this can potentially telescope into public health issues that we think about all the time, just in a different lens. And so we can think about this systematically. People with big T traumas, multiple big T traumas, multiple histories of sexual assault, and other forms of major traumatization often have many little t exposures, whether it's microaggressions, DARVO, bullying, exposure to stigma, and discrimination that are just thinly veiled, hiding under the surface. So when I work with someone in psychotherapy or in a group and team context, I often invite the team members to think about, well, for every time a patient tells you they had a huge assault, how do you try to really see the patient and listen to them and listen for these tiny little littleties that are hiding in the seams, but may actually be equally important or even more significant at certain points than the big T traumas. So I call this the quilt of re-traumatization, where each patch has a way of predisposing the patient to experiencing a brand new adverse and potentially horrific event. We define PTSD and trauma disorders that we're treating in ways you may know, so we'll quickly cover these. So PTSD basically consists of nightmares, flashbacks, intrusions. They could really be in all five senses, like we talked about in Donna's case. Avoidance of trauma cues, trauma reminders, increased hypervigilance, sense of threat. Those are the core components. In Europe and really the rest of the world, there's a diagnosis called PTSD, complex PTSD that we don't see in the DSM. And that includes this DSO criteria, disturbances of self-organization. So emotional lability, relationship problems, negative self-concept, which sounds a lot like shame. And we also have a literature on trauma-related dissociation, and this has a separate chapter in the DSM. And this can include basic dissociative symptoms like depersonalization and derealization, and more varied and potentially complex symptoms ranging from time loss to dissociative identity disturbances and emotional numbing. Complex PTSD is very common, as I'll review in a moment. It's often not really depicted very well in typical media channels. So a couple places I think about are a few years ago, Spike Lee released a film called The Five Bloods, where Delroy Lindo brilliantly portrays Paul, who's a traumatized individual who visits Vietnam with his war pals. And essentially, his complex PTSD leads him to turn the entire visit into a recreation, a new horrific recreation of many of their experiences during the war. And when I was growing up, um, everyone saw Good Will Hunting, Matt Damon's breakout role. And here's the seminal scene where Matt Damon turns Robin Williams, the nice, kindly psychotherapist, into a new version of his dad. And in the film, Robin Williams starts strangling Matt Damon. And then, because it's a nice movie, Robin Williams realizes he's gotten caught in an enactment. He says, "Time's up." Matt Damon doesn't sue him, and they make up, and the movie has a nice ending. So I'm not sure how realistic that part is, but people with complex trauma have a real tendency to recreate new versions of past adversities and traumas in a way that usually isn't fully captured very well, but it's out there. Um, we know that PTSD is very common and underdiagnosed as much as it shows up in the media. This is a review of all known studies that colleagues and I published last year. And these are studies of about two dozen studies, give or take, where we looked at the chart diagnosis and the actual PTSD prevalence in the same patient cohort. And everywhere we looked, not just in behavioral health, but in primary care, showed the chart diagnosis was generally between 0 and 3%. But when you screened or measured for PTSD, current PTSD, not lifetime PTSD was anywhere between a quarter and, in some cases, a half of all cases. So we are, according to all known literature, dramatically under-recognizing PTSD. And there's a second chart I'm not showing today, but more than half, well more than half of PTSD cases likely meet criteria for one of these complex PTSD cases. So the story that is beginning to materialize is PTSD is under-recognized, and most PTSD isn't so-called simple PTSD or just PTSD. It's actually a much more complex disorder that likely started earlier in life. And that is important to consider when we're thinking about what trauma is. Where does specialty treatment for trauma fit, and how does that fit in health systems where we have not just patients, but personnel with a history of with their own life history that may include trauma? We know from our studies of population, is not starting, but largely including the ACE studies, the adverse childhood experiences studies, that trauma does in fact have multiple effects, just like the SAMHSA definition told us. So psychiatrically, we know that beyond PTSD, depression, anxiety, and substance use disorders are the three most common outcomes from trauma, among other issues. Behaviorally, much higher risk for violent behavior, experiencing intimate partner violence, perpetrating partner violence, school performance issues, promiscuity, which is usually defined as having 30 or more sexual partners, and medical sequelae of trauma. Accidents, being a victim of violence, metabolic syndromes, autoimmune disease. Remember that our case, Donna, had a history of asthma and thyroid problems. Exposure to infections, exposure to traumatic brain injuries. There was a really interesting paper that came out of JAMA Neurology a couple of years ago about CTE and how your ACE score, your Adverse Childhood Experiences score, could predict your risk of CTE in retired NFL players, even if you control for years in the NFL and the position that people played. It's really hard to overstate how significant exposure to childhood adversity can be. There have been many subsequent studies since the original ACE study and a meta-analysis. The most recent one that I have is from several years ago, showing that your odds of experiencing any number of really major effects following trauma, apart from PTSD, increases famously in a stepwise fashion from 0 ACEs all the way up to 5 and more. So we know that in specialty treatment for trauma, we're really focused on PTSD, but we need to think more broadly with trauma-informed practices, right? We think about disorders and individualized goals in psychotherapy, high threshold programs like private practice therapy, and similar evidence-based treatments where we follow traditional clinical trial design all the way up to randomized control trials. In trauma-informed care, we're looking at a whole health system, right? We're looking at patients and their experiences and their outcomes. We equally have to work at the health system personnel. So in our research, we call this a concept of duality, where we have to look both at the experience of the service team and their communication and their experience of adversity and how that impacted them, just as much as patients, right? In a clinical trial of say EMDR, we don't report on the outcomes of how burned out the therapist felt or their risk of vicarious re-traumatization. But in trauma-informed practices, we need to care equally about the health system team, which really is not the emphasis in most trainings. We can visualize this. So if you don't have lasting adverse effects, we can call exposure to adversity adversity. If they're lasting adverse effects, we can call it trauma, according to SAMHSA's definition. You can have the psychiatric sequela, you can have behavioral and psychosocial outcomes and medical outcomes. And of course, in a health system, we're looking at all of these in trauma-informed healthcare. We need to look at all of these outcomes and how they interrelate with each other, not just with patients, but with the health system. So it really is a vast topic. The seminal paper on trauma-informed care was published in 2001 by Harris and Fallett, and they identified trauma-informed values. This is SAMHSA's version of those values. And you'll see this is really looking at treatment in a fundamentally humanistic way. These are essentially humanistic values. Safety, that patients and teams need to feel safe in treatment, that patients need to be maximally empowered during treatment. There needs to be a high level of collaboration. We need to build trust, peer support, and increasingly there's been recognition of history, culture, gender issues. Depending what you read, um, this can be a longer list, but this is the list that SAMHSA published. The problem I always had with this is how do you operationalize this? And how do you do that consistently and at scale? That's a little bit more difficult for me. Um, SAMHSA took a first step in answering that in the same article, which is very widely cited and well and often used in this area of research and trainings and practice. And they developed these four categories I mentioned at the very beginning. A system and all its personnel, all the way up to leadership, need to understand trauma. So they call this the four R's: realize or understand trauma. The system needs to recognize signs and symptoms of trauma, respond effectively to trauma, and have policies, procedures, and practices ambiently in place to be guardrails to help patients and personnel not be exposed to further trauma, trying to prevent it. In our research work, we identified a fifth R, repair, to represent the psychological work that really is needed to repair relationships and repair trust when harm inevitably does happen, because in large complex systems, we have not figured out a way to fully prevent that. This is just another graphical representation, and you can see how this is from our research, where we really started to break this down into smaller categories that we could assess psychometrically using validated scales and statistical tools. And this actually started to grow layers and even more layers than I can fit on this slide. But really, the key question for us is how do we start to operationalize this? And what if we're just starting in a health system to implement some trauma-informed practices? And the first step generally has to do with either education or screening. How do we educate patients that you have a symptom that might be from something called PTSD? Maybe these bad dreams you've had ever since you were a small child, maybe they're not who you are. Maybe that's not how life is. Maybe it's a symptom of something that can be treated. A lot of patients don't necessarily know that, and a lot of staff members don't necessarily know that either. At least until they're trained, and especially if you move outside of traditional behavioral health. In the addictions clinic, this really got a lot of traction. basic educating patients. Here's what trauma is. Here's what PTSD, by the way, the things that happened when you were little, they were not your fault and you didn't deserve that. Has anyone told you that before? And that's often a way to start a new kind of conversation with the patient. The second step is to start screening briefly for signs and symptoms of trauma, which is turns out to be not that difficult to do systematically. There are a number of ways to screen. I don't recommend starting with trauma histories. Generally, we're not treating people's histories, we're treating where they are in the here and now. So, what tools are there to ask people about that? The best one, the favored one, is an amazingly brief tool that has uh, at least at least three validated studies, a high sensitivity and specificity for accuracy. The PCPTSD-5, the primary care screen for PTSD, for DSM-5. You can do this in behavioral health clinics. You can use it in general medical care. You can use it at the bedside on an inpatient medical ward. It's five yes or no questions, almost nothing mentioned about history, which is a rabbit hole many clinicians don't have time or comfort going into. And it takes less than a minute to do. This is a really useful, quick, helpful screening tool that we were actually able to systematize in a couple of clinics at the University of Maryland. Quite easily, we could bake it right into one of our EHR workflows. There's also a brief screen for dissociation now, recently validated, and that's a short version of the dissociative symptom scale called the DSS. These are 8 questions. They're not yes or no. You have to choose a number on a Likert scale. And it generates a normal bell curve type distribution, and you can score people's responses. And they have a fairly diverse validation data set in their validation study, which makes it an unusually useful, well-validated tool for a brief screen for some of the more complex symptoms that many clinicians in large health systems might not have had much training on. But there are quick, effective, safe, validated ways to actually screen at scale for both PTSD and more complex symptoms of trauma. There is a brief screen for complex PTSD, but we don't have that diagnosis in the US. So these are the two I focus on here. So we have a definition now, right, for trauma-informed practice, the difference between values and tasks that we're interested in advancing in trauma-informed practice. And a lot of those tasks have to do in helping patients like the one that I got to meet in the ER. A lot of those tasks don't require a chatbot, right? They require the team to work and to be present in the here and now with each other and to work with patients in a way that is more seamless and more compassionate, and where their story can travel with them and be honored at different points in the health system. Remember, Donna's experience largely was being asked the same question every time she comes in, same set of questions by different people, different strangers everywhere she goes, right? And are there ways where we could maybe streamline this and make the system feel a little more human, using the advances in technology that we've been seeing, right? How can we operationalize these tasks and make these values come a little bit more to life? And spend more time human to human with patients without going through the same nearly rote set of questions we often are forced to do. Surprisingly, there's a little bit of research going into this already, right? So if we look at AI use cases in this broader way, we can think about access. How do we improve screening and diagnosis? How do we help with burnout, right? So a negative adverse experience of trauma in the workplace, we sometimes call burnout, we sometimes call it compassion fatigue. There are literatures, particularly about burnout, that focus on these concepts and the effects that burnout have on workforce productivity and turnover, right? So if you include burnout as a syndrome, it's not a clinical syndrome. But if you believe in burnout, not everybody does, but if you believe that burnout is important and it matters, this is a effect This is a lasting adverse effect from adverse events that workforce members experience and that lead lasting negative impacts on someone's experience at work and their ability to perform, right? So burnout, under SAMHSA's definition, may count as a kind of traumatic exposure that deserves our attention. Okay, this is a little bit, I don't know about controversial, but there's certainly not unanimous agreement. But there is, as you may know, a huge amount of attention focused on burnout these days. And the effects that the work, even if we are well trained, have on us are real. And all of us clinicians know that in one way or another. How does teamwork work, right? How does clinical communication and coordination work? Really, care coordination between health systems and patients really is about being heard and being seen, right? Just like in psychotherapy and just like in any trauma-centered, trauma-responsive, trauma-informed practice, right? How do we hear and see each other and make sure we treat and we don't dehumanize our colleagues or our patients? What about bias reduction? So there's some early investigation into these, and the potential is potentially quite large, right? And one area you might look is the informatics literature. There's a lovely review came out last year about a concept I think of as care cycle integration, but essentially by Chen and colleagues, looking at all the different patient care pathways in a large, many of the major patient care pathways in a large health system, and look at all the places where information breaks down, even in the age of large mature electronic health record systems that were supposed to solve all of our handwriting problems, all our communication problems. Lo and behold, we still have these problems. In some cases, arguably, they're more severe than they were in the days of patient charts, right? So we have all this information. We have to exchange that information, but there are major gaps. No one can read a 500-page fax where half the pages are duplicates of others. It's very difficult. And that's what we often see with EHR charts that are transmitted. The patient care journey is difficult to map, especially if they have multiple clinicians, multiple specialties, multiple comorbidities, which is fairly common in behavioral health for patients to have multiple psychiatric morbidities, multiple medical ones. It's hard to stitch those stories together. Updating the information, can we do it more ambiently? And what about helping health systems talk to each other? Interoperability, right? And so this outer layer, the green layer, is the author's attempts to think about how we can do this more systematically, right? And they don't specifically mention patient-centered care, trauma-informed care, healing-centered care. They're different terms of art. But I would propose that this is very much relevant to our considerations and that there are many reasons to be optimistic that machine learning systems, whether they rely purely on large language models or more likely a combination, one of those hybrid solutions, combining large language models and other forms of learning, to really transform the way that we experience healthcare so that patients don't have to be asked the same questions every time, everywhere they go, even within the same hospital stay. Maybe there's something there. Maybe we can replace screening tools and other assessments with more dynamic ways of assessing based on natural language. There is a healthy growing literature on more organically designed dynamic approaches to psychometric assessment, and spend more time connecting as humans. So if we just to briefly conclude, where on these tests does AI fit now? We're not yet in the age of multimodal, fully agentic autonomous AI. We're nowhere close to that, is my view. Certainly not in healthcare. But where does AI potentially fit now? Well, it can maybe help us recognize trauma. Maybe it can help us pick up on signs and symptoms in the words people speak, that we can track fairly simply in a fairly straightforward way using existing tools in a way where we can standardize and minimize error rates. Maybe AI can help us create and implement systemic practices and ways of communicating with patients, ways of making sure their story is constantly updated so that we don't have to constantly ask the same questions all over again. And anyone who's worked in a hospital has probably heard a patient say, "Gosh, someone has asked me that question 20 times in the last day or two." And it really affects our ability to build rapport and human connection and go straight into what matters, which is healing and care and problem solving and teamwork. Down the road, perhaps AI can help us improve education about trauma, even respond to trauma faster. There is active research in all these areas. How can we identify someone's at risk and activate early response systems in a way that prevents them from having to um, uh, be forced into involuntary hospitalization. Maybe we can connect someone with care faster in a way that is safe and effective and um, um, and leaves them with maximum agency in their life. Of course, the risks are huge, right? What if AI makes a major mistake in summarizing someone's chart, right? And it says they have a history of pulmonary embolism when they did not, or vice versa. What if an AI system, a partially agentic system, activates an emergency response or a crisis response in someone who doesn't need a crisis response? And that has happened in early exploration into that field. So there is certainly risk that comes with this, and it's incumbent on our field in healthcare to hold the field of technology accountable and to expect appropriate oversight through regulation and institutions and other mechanisms to make sure that we understand the risks and benefits very clearly. Um, I want to just point out that we live in a dehumanized, often system that feels quite dehumanized, especially for the patients with the highest needs, like Donna in the emergency room. And the need for improvement is unspeakably vast. So I am expecting, not just because technology companies um, want to make a profit, but because there is legitimate need to improve the experience of care for patients who have the least access, who may live in a very rural area, who have the most difficulty communicating, in part because of their psychiatric challenges and their medical challenges and other factors. There really is a need to find new solutions, innovative solutions, and of course, a need on our field to expect high standards for safety and to understand what that means. So I hope a brief introduction to AI. What is an LLM? How is it built? What does a safety mechanism mean? I know we couldn't go too far into details. I think those are going to be critical for us and our colleagues and our health system leaders to really have a grasp on, even if they're not personally technologists, because we need to understand what systems we're buying and hiring to help improve our systems of care. The last R, maybe in some cases the most important, repair when harm uh, does at times happen. Um, Perhaps that's what's going to be the realm of needs to remain, can only remain in the health realm of humans working with other humans. And that is, I don't know for sure, but I suspect going to be what we get to spend much more time focusing on, talking about, and perhaps even researching in the years ahead as we figure out what's going on in this landscape that we're just starting to experience now. We've reached the end of our slides, and there are references at the end for those who take a copy home, and I'd be delighted to field any questions or comments. Thank you so much for having me.
Thank you, Dr. Israel, for quite a quite a journey, quite an amazing talk. So everybody out there, if we have about 10 minutes for Q&A, and so if you've got a question, please put those in the Q&A box. I don't know, Dr. Haas, if you wanted to get us started.
Yeah, thanks, Ben. Thanks for a really interesting talk. And, we share this passion of making sure that patients everywhere get access to um, trauma-informed treatment. And I guess one question that's coming to my mind is, what advice would you give to people who either work in a system or even in private practice, but share patients and share clients with other providers within the mental health disciplines, who are confronted with the challenge of not everybody sharing the same priorities. And, part of the R's were recognizing and realizing trauma is a part of the picture, and these symptoms are there to respond appropriately. But what if people aren't sharing the same priorities of highlighting this as important? How do you help shift the system or shift treatment teams when you may be not having aligned viewpoints across the disciplines?
What a
And
great
AI part of that.
encapsulation, right? I mean, what a great encapsulation of the very human problems that we have in working with large human systems, right? So a colleague of mine who works in quality improvement um, once said, "Hey Ben, do you know ever heard of what's a wickedly difficult problem?" I said, "I don't know." He said, "Well, a hard problem is getting to the moon, and we solved that decades ago. But a wickedly difficult problem is getting everyone in the hospital to wash their hands, right? We still haven't cracked it. We can get to the moon, but when it comes to working with even a handful up to dozens or hundreds of human beings, you have different priorities, different backgrounds coming into the picture, right? So I've really had to become much more humble, which is even more humble than I thought I'd have to be, working in a system that has people with different backgrounds, different trainings, not just personal backgrounds, but vastly different trainings, trying to talk about one patient. And sometimes it's like you're in multiple realities and you're wondering, what patient is this person talking about? And then you remember you're actually talking about the same patient. And what I don't think I have, I wish I had a great answer. The best, the least bad answer I've come up with is attempt to not be too imposing on the person I've talked to and try to sometimes hear between the lines of what they're really trying to say. They may be struggling with the case, they may be focused on a medical issue or another aspect of the psychotherapy, and attempt to communicate in language that a non-trauma trained professional might find resonant, right? So that's one reason I really, the most important thing I've done to this date and as a researcher is that review of how little um, parent training there is in psychiatry for PTSD, where we have more than an 80% under recognition rate. A lot of times it's not the psychiatrists or the therapists or the case managers or the other physicians' fault that trauma isn't, or a traumatic exposure may not be the top of their concern. We didn't even have PTSD until 1980, and that was after two world wars and a lot of other, so many countless other experiences where trauma is really hiding in plain sight everywhere. And I've really gotten a lot more, I think, better at understanding that and recognizing that uh, we have to just stay humble and use language that other people can hopefully hear, and also hear that other clinicians have expertise that I'll never have. And I know that sounds a little bit um, uh, maybe canned, but it's true and it's helped me.
So, Ben, we have 5 minutes left, and we have buckets of questions around trauma and buckets of questions around AI
All
that we're,
right.
not going to get to. So let me just pick one here that I think is a really important question for us all to hear you talk about. And this says, can you speak more about re-traumatization? I'm familiar with how the choice of treatment can re-traumatize clients with undiagnosed complex trauma. For example, starting CBT when the client is not emotionally and somatically stable. I'm wondering if you can share some other examples of how people can be re-traumatized in treatment.
So that's great. So in the complex trauma world, we have a expert consensus model called the triphasic model for treatment. And the three stages are: first, you stabilize, help someone stabilize their safety and their symptoms and their life, really, including their social determinant issues, which we often don't think about in the therapy land. Most people who come in for private therapy, they have stable housing and other key pieces, but in health systems, it's often much more complex. So you stabilize, then perhaps you can process memories, that perhaps you can help them reconnect with their life and internally with their own mind in different ways, right? And I think this is a very commonsensical approach. So a simple analogy that I often think about is think about any other injury, right? If someone gets hit in a motor vehicle accident and they broke both hips and they have complex fractures and infections, right? And they say the next day, I'm ready to start training for the marathon again, right? No one in their right mind would recommend that. We know from we don't need to do a study showing that someone with a fresh compound fracture of both hips should not be doing marathon training. They shouldn't even be walking with a walker. They need to stabilize the injury and rest, right? But for some reason, that same logic has not really been the main framework in trauma treatment. We have evidence-based treatments of largely, ideally healthy patient groups who show responses to high exposure treatments like cognitive processing, prolonged exposure, and EMDR. And in many cases, that is a little bit like someone with a major injury going into rehab way too fast. And the risk isn't just that patient with the broken legs or hips, they're not going to get stronger. They're actually going to get weaker from trying to train, and the injury could get worse. And we don't have enough research showing this in the empirical literature. It is hard to motivate researchers with limited funds, particularly in PTSD research, to look at these questions. But from immense anecdotal data and from Dr. Haas's in my previous role at a national referral center for complex PTSD, one of the most common chief complaints, somewhere between 5 and 10% probably, was um, things were kind of going okay until I had exposure therapy. And then my symptoms fell apart. So this is a really great question because I think there's a huge calling for research to really clarify what is going on. This can't just be Dr. Israel's opinion, but this does seem to really make sense for a lot of patients, and I hope that helps. So we go slow, we stabilize the injury, and then we slowly build up. Well, can you stand on it? Can you walk a block? Can you walk 2 city blocks? And then we build up to jogging, and then eventually we're marathon training again, just like any other injury. So
You, you remind me, 30 years ago in in running the PTSD programs at the West Los Angeles VA, we had psychoeducation groups and a whole kind of stabilization program first, and then a re-exposure program, and then a welcome home program
yeah,
about building relationships and kind of welcome back to life and you're more than your diagnosis. And in those three, so this is a yeah,
yeah.
I'm just riffing on your idea of commonsensical. Yeah.
And if I could riff with you, Dr. Caspin, to my knowledge, there is exactly one paper ever published about the importance of psychoeducation in therapy for people with trauma and in trauma-informed
Mm.
treatment. And it's if you can't realize and understand what's going on, it makes sense. A lot of psychotherapy really is psychoeducation,
Mhm.
but there's a huge gap in the research that any researchers on the call, I hope, might be interested in. And I cited that paper. It's by Dr. Whitworth and colleagues. If you happen to download the slides, it's right in the references if you're
Great.
looking for it.
So I think we're at time. I think we're at time. We
Thank you
have
so much.
many more questions. Maybe we can send those to you, and there's a way that maybe we can get them out. Let's see what creative sparks we can engender here. But Dr. Israel, thank you so much for being with us on ending our 2025 Grand Rounds series um, in such a trauma-informed way.
Thank you
And
so much.
Dr.
Thank
Haas, thank you so much for bringing your
you.
wisdom and for bringing Dr. Israel to us as well. So thanks to you both, and thanks everybody for being with us. I don't want to hold it people over. So back to our lives, and great to see everybody and be with you.
Thanks.